So the Office of Health Equity's mission is to evaluate a wide variety of specific health outcomes among diverse populations to fully understand the depth of health disparities in Erie County and to partner with community members, healthcare providers, faith and philanthropic leaders, and organizations to enact programs that help disadvantaged, marginalized, and diverse populations in Erie County achieve maximum health and wellness. Their vision in their newly established office from not too long ago is that all disadvantaged, marginalized, and diverse populations in Erie County who presently experience higher rates of poor health outcomes achieve maximum health and wellness. So I had the good fortune of meeting Kelly for the first time as part of the Community Health Equity Research Institute. She was one of the founding members and is in a leadership role amongst that group. She was warm, she was welcoming. She's been so accessible since I stepped into my new role. And every time that I've called to ask for advice or help on something, she always says yes, and thus she's here today. So very excited about that. Very much appreciate, and Dr. Murphy is actually going to give us a bit of an overview about the wonderful team at work across the Community Health Equity Research Institute for the next part of the presentation, but just very fortunate that she's here with us. Thank you to the entire group that put together this amazing report. It looks like no small lift, as you can probably all nod your heads and say yes. And then I'll just say, I think for those of you that met her today, or those of you that spoke with her when she got here, because she's spoken so much to so many groups across our community, we're very fortunate to have somebody in your role in such a leadership position and so committed to our community. So thank you.
So I am Kelly Marie Wofford. I am the inaugural director of Erie County's Office of Health Equity, and I serve all of Erie County with my incredible team, half of whom are here today, and the other half are at the Women of Color Summit that's happening in Buffalo, Niagara Falls. So on your tables, there's a QR code that leads you to a report from the Office of Health Equity. That is our first report. If you are interested in this report that I'm going to be talking about today, if you go to this link, erie.gov/HE reports, you'll be able to pull up the 2023 Health Equity Report. So just a quick overview. We're going to do a lot of talking. Jill told you about the office. We were established in 2021. And by 2021, I started December 20th, 2021, but we're claiming the whole year. And so there are a couple of things that we're tasked by law to do. So we weren't created by an executive order or a grant or a well-wish. We were created by a law. We, by law, exist and will continue to exist. That speaks to the testament of those that put in the work prior to my hire, December 20th of 2021. And the ability that county government, that the work that Tim and Pastor George and myself all together with the other folks in Erie County and Buffalo working in health equity did to show that it was necessary. Mind you, one shouldn't have to show that it's necessary, but we did show that it was necessary to create an office that addresses health equity at this level of government. So these are the takeaways from the law as far as what our functions are and what we're by law to do. What's interesting is in the functions of the office, none of it says solve. It says test, to figure out, to analyze, to connect the factors, to put the pieces together in a way that makes sense. One of the best parts of this is the ability to fail, to trial, to recognize error in looking for the solution. So often, especially when we talk about grants and funding opportunities, you have to meet this deliverable, you have to meet this goal. You have to prove that the thing you did worked. But when we're talking about a space that is relatively new, in order to get to that point of knowing, you've got to test some things out. Anybody that has children, did you get parenting right the first time or second time? Or my kids are grown and we got one, right? So trial and error, right? We do the best that we can with the information and knowledge that we have. The plus is we have a lot of data, we have a lot of information and a lot of knowledge around health equity, health disparities, and health outcomes. I will not be talking to you about specific health outcomes today. That stage has already been set. And so what I will do is just tell you a little bit about why this survey came to be, why this report came to be. And we did some last minute brainstorming over here during the last presentation, because a lot of the questions that were asked and the points that were brought up are actually discussed in the report. So I want to speak to what's already been spoken to in the room today. So just bear with me as we transition and get to the good parts. And we're going to bring up Mike, our lead epidemiologist, and we're going to talk about the data. Again, if you want to pull up the report, it's going to be great for you to be able to see that. We're going to do that here on the screen too, so you can actually see what it is we're talking about. So a little bit about the work of our office. This is about half of the things that we do in this office. One of my initial purposes, and it's still the purpose of our work, is to be of an assistance. We are a government office. We are still dealing with the fact, most of us, that we work for the government. But how can we use the fact that we are truly a part of the system in order to change the system? And so we offer grant assistance. Mel LeMay, our grant specialist, is here. Some of you may have worked with Mel. In the last 2.5 years, Mel has helped organizations apply for, I've been here 2.5 years. Mel has been here a little over a year. And in that time has helped organizations apply for over $11.5 million of funding. And that was at the time that this report was written last year. And I think we're at about the 4 million mark of funds received. Mike, who you will meet in a little bit, is our lead epidemiologist. Lara is our assistant epidemiologist. And the two of them provide data support. Anybody here? Now, I feel like someone may say yes more often than a usual group of people. How many here are epidemiologists, love data, are like, ooh, that standard deviation, I'm here for it? One, I know there's 2 or 3 here, right? That's not my specialty. That is not my ministry. That is not my gift. That is their wheelhouse, right? And so we have so many organizations doing the work in Buffalo and Erie County. Their specialty is not data. Their specialty is not grant writing. So how can they adhere to their mission of doing the work when they have to focus on things that are not their specialty? So one of the things we do is provide technical assistance in that space. Mental health first aid is one of our flagship programs. I'm gonna shout all of you guys out, so just be prepared. Eddie Payne is one of our educators, and he leads the mental health first aid program. If you've taken mental health first aid, it's a generalized 8-hour class, but the purpose for us is to change the conversation around mental health. Change it in a way so that when and if someone has an issue, we are all equipped as Erie County residents to be able to meet the need of the people. I would love for us to be able to blink our eyes and raise up all of the therapists and social workers and psychologists and psychiatrists that we need in our community to truly address mental health. Also, if I could blink and do it, it would be done. In the meantime, we all have to figure out where we fit in this puzzle and in this system. Mental health first aid allows us to do that. And so we will come out and provide mental health first aid wherever you are. It could be a farmhouse, just as long as it's more than 4 people, because we're not just going to go to some random farmhouse. But we will, anywhere in Erie County, come out and deliver mental health first aid. Bible study takeover, food pantry, ECMC, it doesn't matter where the people are. So that is another service that we offer. Our newsletters and language access. Anyone seen one of our newsletters? You get that? Newsletters tend to be very downstream. The purpose of our newsletters is to provide information to the people in a way that's easily digestible and addresses upstream issues. One of those newsletter topics is working in government. I don't know if anyone has ever tried to get a government job. When I tell you it's not easy, it's not easy. With a degree or four. And so how then do we tell folks who may or may not have formal education, oh, just go apply. There's an application, there's an exam that they don't test on any information from the 20th, 18th, 17th century. Like, they want to know if you know how to actually make paper, right? They're not asking you anything that you actually need to know in order to do the job. But in order to get that job and keep that job, you got to figure out who's going to do that. So my office is working very hard on not only helping to change the system, while we're changing the system, giving people the tools that they need, because in the meantime, people need to work. In the meantime, people love great health insurance, right? In the meantime, we have these resources like our newsletters that are translated into 6 languages. The newsletter is available in English, Spanish, Bengali, Burmese, Arabic, and Swahili. All of that is available on our website. You can sign up for them, we'll deliver them, because again, we have to be able to meet the needs of the people where they are. When it comes to the report and leveraging our voice in government, last year for our first report, and last year in our first report, we included 2 acknowledgements. One was a land acknowledgement. Dr. Hooper spoke about trust and mistrust. One of the ways that we begin to combat that is to tell the truth. One of the ways I can do that as the director of the Office of Health Equity for Erie County is have the government tell the truth. And so our report starts with the land acknowledgement, acknowledging that this land was stolen, that people were murdered in order to take that land from them. In addition to that, it includes an enslavement and labor acknowledgement. That while that land was being stolen and people were being murdered, people were being stolen and people were being murdered in order to come build the land that we all love. The government has said that. This year, we included a community recognition and acknowledgement, realizing that most of us all come from community-based organizations and hearing the struggles that my staff members go through and justifying to their friends and family why they now work for the government. So not only do they get up and come to work to fight the fight, but they have to go home and justify why they're fighting the fight for the people that built the system that made the fight necessary. And so how can we pay homage? How can we honor those that have come before us? Just this week, Buffalo has lost an incredible warrior in Gail Wells, who her absence, she will forever be with us. Y'all may not know my grandmother, but Esther Wofford was no joke. The work I do is because I learned from her. And so how can we ignore our past and think that we're going to build a better future? It's not possible. And so these 3 acknowledgements are the foundation and the bedrock of our report. So on to the actual reason why you came here. We developed a health and wellness survey. I started at, COVID is still real, so I won't say the tail end of COVID, but the world began to open back up around the time that I started my position, and none of the data reflected what we were going through. You all know data is 5, 6, 15, 20. People are quoting stats from a while ago, right? How could I walk into a position to talk about health disparities, health equity, to be able to do the work when we didn't address the greatest event in our lifetime across the world? So I wanted us to be able to have something to hold on to as our foundation, as our bedrock, and that was the birth of our survey. Y'all can read, that was a timeline. I put together a focus group, some of those, or a work group of community-based members. I will say this, depending upon where you sit, community is different, right? So if you are a UB faculty member, community is not going to be the same as the community I'm talking about as the director of the Office of Health Equity. So I put together a group of community folks from the perspective of the government, which was inclusive of academics, of everyday community members, of people that do this work, to be able to guide us in creating a survey that would ask and answer the questions we really wanted to know about. Do we really want to know how many vegetables people are eating every day? You may, I don't care. Because if you were eating the vegetable, if you were doing the exercise, if you were going to the doctor, if you were in school and graduating, if you had if you had all of those bits and pieces, would we be in the position that we're in? And so we asked questions from the perspective of perspective. What are the challenges? Are you eating them? Yes or no? Recently diagnosed with diabetes. I love vegetables. I may not get my 5 in, but I'm not gonna vegetable my way out of my current situation. Even with my education and all the things, there are other things besides 3 to 5 vegetables per day happening. And so whether or not I'm getting them or not, the question is, what are the challenges? If you get them, do you know what to do with them? Are they affordable? We know for most the answer is no. Why not? When it comes to your financial future, do you have the tools that you need? If you were given $1 million today, not one of the questions, but the thought process, if you had all of the money you needed, would you know what to do with it? Do you have a plan for that money? What happens when all of the things kind of fall in place? If that mysteriously happens for you, do you then have all of the other things you need in order to be healthy? So that was the perspective. This was our timeline. And we wanted to be able to, prior to demographic questions changing around race, we addressed that from our perspective. And we put together a survey that not only disaggregated race, we added MENA and North African as an option. We disaggregated Black to encompass all of the diaspora. We disaggregated Latino and Hispanic. We disaggregated Asian because, you know, most people on the face of the earth are Asian, but we're going to put them all in one group. It just didn't make sense. I mean, it just didn't make sense. But in addition to that, that's what we were called to do by law, right? To begin to address health disparities and health equity from a perspective of race, zip code, location. 2 types of tests, or it felt like a test, but 2 types of question options, Likert scale, and most were multiple selections available. Everyone given the opportunity, for the most part, to say, I don't want to answer this question. We cleaned data on the back end, so if people just said, I don't want to answer, we counted that survey and put them in, you know, for our incentive, but we did not count that data as good data for the purposes of the things that Mike and Lara do. So demographics of respondents, this is a shot of Erie County and of the city of Buffalo. We partnered with Buffalo Center for Health Equity and the Witness Project to be able to dive deeper into the Black community, primarily because when we look at health disparities, Black folks tend to be in the highest when it comes to disparities with the worst health outcomes across the board. All of our outreach for survey, all the outreach we did as an office, so going out into community, was purposeful. So we purposely went into rural areas, we purposely went into certain suburban areas, we purposely went to various locations throughout the city. We went to various locations, including Lackawanna. We were very purposeful. We wanted to be able to amplify the voices of people most affected by social determinants of health and poor health outcomes. We did, Um, Folks wanted to help, and so they shared the link to the survey. And when it went out over social media, because we were doing really great on reaching the people we knew we needed to reach, we had an upshoot of responses from middle-aged, educated white women. I love them as human beings. Keep filling out those surveys. But for this survey, that voice wasn't the voice we were looking for. So we had to double down, and that's when we partnered with Pastor George and the Witness Project, again, to be able to get the voice of the people most impacted and affected by social determinants of health. So here are some of our demographics, who we reached, what that breakout looks like. Eddie and Wafa, Wafa is another one of our educators, did a lot of work building community and talking to people, building relationships, being able to pivot when one group of people is expected and you end up at a park and nobody speaks English and you don't speak the language they speak. How do we navigate in that space? By being human, by having some newsletters in the language that they speak. We only offered the survey in English. We had the option, like you could do Google Translate, but we did not translate the survey in and of itself. We knew that up front that we weren't going to do that. We didn't have the resources at the time. All new to government. We didn't even know how to go about doing that at all. And so one of the things we decided to do as the results started coming back in and they were having the experiences they were having in community was to also build in focus groups. So yes, we have these responses, but we need to be able to talk to the people that we could not give this survey to. And so our intention there was also to have those translated. Did not also work the way we anticipated because systems are systems and they do the things that they do. But we were able to not only have the results demographic-wise that we did here, but also in our focus group breakout, we were able to reach more folks that could really tell us about those experiences and what that means and where we need to go. So this is some additional demographics based upon the questions we asked. Again, census data exists, but we wanted to be able to break out their responses as much as possible to be able to really look at the reasons why health disparities and poor health outcomes were affecting the respondents the way in which they were. So a little side note on this, I won't go into detail in the actual report, or the report, which is 324 pages, is just a summary of what is available with the data that we collected. So these are some of our demographic questions. We wanted to, in looking at the data, be able to present it in a way that made sense, in a way that anyone could pick up the report, even though it's lengthy, but pick up the report and be able to do something with it. The report in and of itself is actionable and purposely built that way. Each of the survey sections are broken out by social determinant of health factors. And so there's a section on economic stability, a section on language access, social and community context, education, healthcare system, and neighborhood and built environment. We've modified this pie chart and we use this in our work. And it's really the kind of bedrock of how we look at talking about the factors that contribute to people's health and in a way that allows everyone else to be able to do the same thing. This is available as a resource in those same 6 languages. And so again, what can we do to be a resource? We can put together something that is visually pleasing, but we can also translate it so that when you are working with your patients, clients, family members, community members, you're able to have questions, you're able to have a conversation in a way that allows us to speak the same language. So our first section was economic stability. What we've done here is included some of the focus group quotes. Mike and his team are working on putting together the report of the focus group, but their words married the data. And so they combed through and found quotes from the focus groups, of which I was a facilitator for all but 3 or 4. And to hear people be comfortable enough to tell you their business and you're a stranger means a lot. The work has to be done in a way that people feel comfortable being themselves. And when you go back to use that information, use it in a way that honors them. So we honored all of the participants of our focus groups by using their words. It hasn't been cleaned. For the most part, we might have abbreviated, but you see where that's happened. There's a couple cuss words in there. Don't tell Gail. But that's what the people, who am I to tell someone how to talk to me about their life? And then who am I to then turn around and say, I'm the director of Erie County's Office of Health Equity. Let me paraphrase what someone said because I think their words should be said differently. We do it all the time. So again, giving homage and paying respect to the people that gave up their time and vulnerability to be open with us about where they stand, who they are, and what we can do to show up for them. So when we looked at economic, I cannot see you guys. When we looked at economic stability, we wanted to know not how much money you make. We wanted to know not how much you spend on groceries. We wanted to know, how do you feel about your situation? Because when you look at Buffalo, we're one of the poorest cities, right? So if you are someone that has, what does that actually mean in your day-to-day life? Do you feel financially secure? Why is that important? Because you spend different, you treat people different. We already know how much people are making and not making. We know how much rents are. We can pull that information from data sets that already exist. Here's what the data says. Pull up the census. How does that affect you? And where can we meet you to make that different? Here's some additional economic stability info. It's 241. What I would like to do, I'm going to click through these so you can see them. I want to bring up Mike. We cracked open the report because there were some issues or some topics that came up in Dr. Webb Hooper's presentation, and Broderick brought some questions up that we actually talked about in the report. And if anybody went to the actual website, I want to talk about the healthcare system. If you want to go to page 122, you want to come up, Mike? Or you want to talk from your chair? No pressure. However, I want to meet you where you are.
Sure, this is working.
Yeah.
Yes.
Okay.
All right. Yeah. So yeah, I'm Mike, the lead epidemiologist for this report, and just a couple of things I'll add while we're kind of getting the report pulled up. We definitely learned a lot through this process. The way that the information ended up presented in this report was a little bit dictated by some of the challenges we ran into. We had initially thought of using all of the quantitative data from this initial survey to shape our focus groups, and we get all this done within a year. We'd have a great comprehensive qualitative, quantitative report all in one thing. And that didn't happen. We are still working through the qualitative information, but as Kelly said, we thought just the numbers I think are pretty compelling, but we wanted to at least add a little bit of extra added voice from the community, and including some of those direct quotes. So that's a little bit of a plug of probably the next report that comes out, which will be the full focus group analysis, which really dives into the qualitative data as well. So that was one big learning point, was the scope of timeline we need to take. But But another thing is, as Kelly expressed, we really were looking at the challenges themselves. And so trying to shape questions that really get at people's, the challenges and having them express those is nice in some ways, but does present some additional challenges along the lines of kind of separating how those things are then directly connected to health outcomes. And so we do try to present some of this information and kind of, I think if this presentation goes out from today, you'll see what we tried to summarize within this presentation was kind of presenting the challenge, some of the information around those challenges, demographics that interact with those challenges, and then we tried to make at least some connection with health outcomes around that social determinant of health. Of course, again, the epi folks in the room, the causality stretch there is not what we're trying to do. We're just trying to highlight that these are challenges that the community face, and they do seem to correspond with some changes in health outcomes. And so Kelly, now that we have, I think, this pulled up, do you want to discuss that?
So you can. We are in the healthcare system section. And so this came up, trust being a factor, trust being an issue. What do the people say when it comes to trust? And so one of the questions was about how do you feel you're viewed by your medical professionals, right? And so it's a difference between saying, oh, there's medical mistrust and we think maybe they don't trust us, and asking people, what do you think these people, meaning some of you guys, feel about you? How do you feel you're treated by your medical providers? What does that mean to you? Do you feel respected? Do you feel believed? Because when we look at health outcomes, Black maternal health being one of the hot topic health outcomes right now, right? We're talking about an issue of trust. It doesn't matter how smart you are, it doesn't matter how much education you have, it doesn't matter how much money you have. Pastor George brought up a point in another meeting. If Beyonce and Serena Williams have issues and almost died in childbirth, what chance does Kelly Wofford have, let alone these Black women who we don't know their names? So how can we help them and help you better see yourselves through their words? I'll give you this so you can you see the screen or no?
Oh,
okay.
I'm very blind.
I'll work that.
So yeah, these questions were a series of Likert questions that were presented within the survey. And I think Kelly said something to this respect, is that we ended up with a lot of data. And so for any specific question, we kind of tried to select one variable within that we found compelling for this topic, but clearly we could cross-reference the responses for I feel providers respect me, believe me, the provider is understandable, and they are competent in treating someone like me. That could be crossed with any one of those demographic factors. And so as we repeat throughout the report and as we speak with the public, that is information that we are glad to share with anyone that's trying to address these issues. And we could, if you're focused on those that are struggling with disabilities or a veteran population, this data now exists for our community on how those individuals feel with medical care. And so there's a couple of examples within the main text of the document that speak to these four Likert scale questions, and then there's additional figures in the appendices of the document that also touch on those same questions. And so you can see, I think, what do you have pulled up?
This one is treatment by providers, so broken out by race. And as you can see, I mean, between color scale or numbers, if you can read it, the health disparities are evident in treatment, right? And not only by race, but then also by education level. If I can pull this down a little bit so you can see gender as well. And so what we find is nothing earth-shattering by way of did we know this or did we not? Yes. Go ahead, Sarah.
My name is Satish. I'm from the Department of Hematology Oncology, Jacob School of Medicine. I'm the PI of the Social Determinants of Health Cancer Research. So we also run a qualitative research, assessing the patient's opinion. So what we have found that certain group of people are not going to some of the hospitals here. They're restricted to some hospital. And the trust is one of the issues, one of the most important factor here. So we talk about the physician mistrust, all of these things. But going not to any particular hospital and pointing to only to, for example, few of the patients are very comfortable going to ECMC, but not to other hospitals. So how do we navigate this? I mean, this is a bigger issues, for example, considering access to care and other issues. How do we navigate this one? How do we have a intervention to improve this one?
So I think that is a question that so many people have. Like we have the data, people are dying. What do we do? How do we do it? I think here in Buffalo, we can look at bright spots. So UB's medical school, right, redesigning the curriculum to be inclusive of social determinants of health, so that the providers are aware that Black people don't feel more pain than everybody else. Like we do not have a higher threshold of pain. What hurts, hurts. But if you're taught that science has proven, while debunked, proven that Black folks can tolerate more pain, how do we then say and teach that is not true if you don't have to be re-educated? You got your degree, you got your papers, you got your letters, you don't have to, you could take a CME on whatever you want to take a CME on. It doesn't have to be on health equity, right? So we begin to bake and cook in to the education truth. It comes in ways like those three acknowledgments. This land is stolen, people were stolen, people are still being stolen, and we need to do something about it, right? But until we address and acknowledge the truth, it's very difficult to apply a Band-Aid to a situation. Like, why are we putting a Band-Aid on someone that has breast cancer, right? Like, you're looking for an answer for something that the answer doesn't fit the situation. But if we don't know what the situation is and we're afraid to talk about it, how can we then address it? So some of it comes in that truth telling. This particular quote is one of the ones that Pastor George and I deal with a lot. People are dying young. So this participant at the Black Eastside Residents Focus Group says, I got a friend, he was 44, he just died. He had a heart attack 2 weeks ago. He did not have health insurance, so he didn't go to the doctor. He had a full-time job, but not enough to afford the health insurance. But if you talk to Suzanne, is our new project coordinator, she comes from Cancer Services. She had a grant to address cancer. She knows where to go, but the grant doesn't pay for it. So what is she supposed to do? We have to be able to have systems in place, like an Office of Health Equity, like a Community Health Equity Research Institute, like a Buffalo Center for Health Equity, working together to be able to go exactly where we need to go and say what we know we need to say to the people that aren't going to go to the doctor, that can't get to the doctor, that don't believe the doctor when the doctor speaks. Like, we know what we have to do. We just need to do it. Most of us are here in our professional capacities. So outside of your professional work, what are you doing to change the system? Is it exhausting? Yes. Do I get into fights with people about comma placement? Yes. Why does that matter when people are dying? But for me, I have to take a step back and say, a researcher, a doctor, a dean, a president, or someone's going to read that report, and if that comma is not right, no matter what I know to be true, is not going to be heard, because it's going to be seen as inferior, less than, insert the words of how people are seen when they don't show up in the way we think they should show up. So that's the long answer, is to do the work.
Are there any questions online at the moment? In the chat? No? Sure.
Okay, sounds good. Hi, my name is Rubelisa. I'm from the School of Dental Medicine. I just wonder if any question address dental care access or oral health outcomes.
No, is the short answer. We didn't really dive in depth in terms of healthcare access, like in specifics. I will say that that is definitely an area we're very interested in exploring further and like breaking out all of the individualized challenges around healthcare access as they are specific to things like mental health, dental health, the whole body. I don't know why we separate the whole body in this country, but yes, that's actually one of the other projects we'll be turning to as an office is the community health assessment and the community health improvement plan. And I know healthcare access in general is an area that we're probably going to be surveying more about. So more to come. So hopefully we'll have some data on that too.
We did have the one at human beings in certain geographic areas. So the question was, did we look for specific people individually when we did the survey? And so no, we went to the places where those folks are because we needed to hear from everybody in that space, right? And so we're not only going to talk to the Black people in 14215 because I can't disaggregate 14215 by anything but Black people, right? Are we here? Anybody want to fill out the survey while we're here, right? Like, would you, right? And so no, we did not, anyone willing, and I won't put you on the spot. You can talk to Eddie after and talk more about what that was like for him in community to be able to have those conversations with people. To your dental point in our conversation earlier, we did a focus group with rural caregivers, and this is also in the book under healthcare systems. Their quote is, "There's wait lists for everything. The primaries, the dentals. I just tried after looking for a dental office. They're no longer taking my child insurance. My child has special needs. I can't find a pediatric dentist. Took me since January to find one because the wait list for 2.5 to 3 years long. That's crazy. That's unacceptable." They said it took them since January. We did this focus group August. So from January, they started looking in January. It took them until August to make an appointment. So there are systems that are quite frankly out of my control, but I can illuminate the story. I can share the data so that when you're in state meetings, when you are in federal meetings, when we're in state meetings, when we're in conversations with people, we have the voices of the people. We already know that HealthyLink has the data, like the data is there. But what does that mean when we translate that into real life situations? And so that was our attempt to, this report was our attempt to translate real life situations. But here's the thing, in looking at other surveys, we have laws and policies and rules and regulations that have been created off of surveying 300 people, 50 people, 500 people. We talk to real life people, or they interacted with our system, real life people, over 3,000 people, and their answers and results are in this survey. Not 500, not 200. We had over 5,000 responses, but once Mike and Laura did their data cleaning,
Robots.
they were able to pull out the robots to leave us those real life answers, those real life people, those real life issues that folks are having and facing. And so there's not There's not enough time. But what we are able to do is put together, this is written in a way for you to be able to take one page and use that one page. But we are able to put together additional responses to let you know what people are saying based upon the data that we collected. We're able to help primarily small community-based organizations. I'm not saying UB has resources, but UB has resources to be able to do these things, but to be able to be a resource to those that don't have. And so I encourage you, if you have grad students, give them the, like if you don't want to read it, I think y'all should, but have them do the reading and the explaining and the understanding. Yes.
So I'll try to be quick. My name is Leah Bartlow. I'm with, I was with a program called Lead 716 for early childhood children who were lead poisoned. And when COVID happened, I was concerned the program would run out, so I switched to UB. I'm about to start my dissertation. The focus of my research is prevention, navigation, and mitigation of lead poisoning in Buffalo. My poster in the corner there, if anybody wants to check that out. I really wanted to ask, because I do believe that lead poisoning is a root cause of a lot of health inequity. A couple of questions that came up to me that I just really wanted to get an answer to is, one, in your study, in your research, did you just speak to community members, or did you also speak to any providers on their take of that whole trust issue in particular? And then another is, I'm really curious to see if you had any surprises in the data, something that you really didn't expect. And then lastly, I just want to say, Mike, that my dissertation is going to be mixed methods, and I'm a little nervous now. I might be overambitious with what you reported in your experiences there. Anyway, thank you very much.
Thank you. So quick answers on the providers versus, or just providers in general. We did not seek out providers. Providers are people too. And so if they were in the places and spaces that we were, and they were interested in filling out the survey, our request was of them was to fill out the survey as themselves, not as the provider. Because Black providers are dying before the white ones. Like, health disparities exist across all areas. Like, so what are you, no matter what your job is, how are you addressing, how are you feeling, how are you managing in this space of social determinants of health? Surprises. I was surprised in a focus group when a participant said, I pay my rent every month, but I got water running down my walls, and I live upstairs. So when the water from the sink runs into the wall, it pours out into the downstairs tenant's kitchen and bathroom. And so it cuts off the electricity. So we don't have electricity. And I try not to use the water too much, because whenever the water runs, it runs into the apartment downstairs. That surprised me, because even though I know someone took time out of their day to come to my funky little focus group, but was vulnerable enough to tell me, I can call the rest of the health department for you, right? But my team can't come out but they live in the city of Buffalo. If they tell on their landlord, they're afraid they're going to be evicted. And they're afraid to be evicted from a home that doesn't have electricity, because when they run the water runs down the wall, and they pay their rent. That's what people in Buffalo are living with. That's what people in rural Erie County are living with. This is not just a Buffalo issue. Our rural folks didn't surprise me, but I was glad they noticed. Several times it came up, we have an elder abuse issue, but our politicians don't want to hear it. They say that doesn't happen here. I'm like, well, we had a table in the middle of a rural place, and you're saying it's happening. So clearly it's happening, at least here and amongst the people in the room that are all nodding and agreeing. That did not surprise me. It's in the book too. But those were the things that people shared. Those are the story. Like, those are the people that are coming to work every day, and they're like, why are they late? They didn't have electricity when the water was running down the wall, right? Like, so let me write them up oh, but their English isn't too good, so they don't know what I'm saying. No, like, there's so many layers, and there are laws and policies and rules that say all of this is illegal. So if the policies and rules and laws all say this is illegal, what's the law gonna do? This is a me issue, it's a you issue, it's a you issue, it's a you issue. Y'all got friends that own property? Tell them about that person who got water running down their walls. Do you own property? They might have been talking about, well, I don't know. But you know what I'm saying? Like, we are the solution.
I'm sorry.
I'm sorry.
We have the next speaker starting actually in less than a minute. So I pushed her off for about 5 minutes. Perhaps you guys can connect after, if that's okay. Thank you on behalf of all of us, to you, to your entire team for doing this really critical work. There's so much data, as you can tell from even just looking at the sheer size of the document. And Kelly, thanks for your commitment to all of this and for doing this for us today.